So it's 2:30. So I'm going to welcome you all to Complement 3 Glomerulopathy, Current and Future States. This symposium has been compiled by the three of us here as the faculty, and welcome to this session. I'm going to say a few comments about what we're going to try to accomplish, and then I'm going to introduce our speakers, including myself, and then I'm going to show you the agenda, and we'll go from there. So it's a very exciting time in nephrology because there are all these diseases that we are now exploiting our understanding of the pathophysiology to design and direct very specific therapies. And this disease group of two diseases, the C3Gs, is an example of that, where our understanding of the pathophysiology that our first speaker will address has allowed us to move from our current therapies, which are largely unsuccessful, which I will address, and we will have in the very near future, and even currently, some very new therapies that may dramatically alter the prognosis for these patients, which is quite dismal in the current state. So it's a very exciting time, and I'm here to learn with you, and hopefully you all come away with some new understanding of the disease state. So let me begin by showing you this is the agenda in order. Dr. Purva Sharma, who I'll introduce in a second, is going to start us off by talking about the pathophysiology, and in the context of that pathophysiology, the evaluation of patients with C3G, including all the latest science for markers and other strategies. I'm going to introduce two cases of C3G to allow us to practice what we've learned from Dr. Sharma, and as well as I'm going to discuss the current state of treatment as it was outlined in the last update of the KDIGO 2021, but even still would probably be current through 2023 or 2024. And then Dr. Benjamin Wooden is going to talk about the future landscape of C3G treatment, an update on investigational therapies, and some of which have now been approved. So we're really on the cusp of having new insights. I remind you all to turn off your cell phones and to be sure at the end of this presentation to take some time to evaluate what we've done. Let me begin by giving you a little bit of the bio on our speakers here. Dr. Sharma is a board-certified nephrologist and currently the co-director of the Glomerular Disease Center at the Donald and Barbara Zucker School of Medicine at Northwell. She completed her internal medicine residency at the University of Connecticut and a nephrology fellowship at Johns Hopkins. Her clinical interests are in glomerular disease, and she's widely quoted and has played roles in a number of international and national organizations in this topic. And she's currently also the co-director of the Gallid Fellowship in Onconephrology and glomerular disease, I guess the intersection of those two as well, and heads the glomerular disease trials and research division at Northwell. So we're very privileged to have Dr. Sharma here. Dr. Wooden is a assistant professor at the Columbia Medical School at Columbia University. He graduated from the Icahn School of Medicine at Mount Sinai and then completed his residency in internal medicine at Columbia, followed by a year as chief resident, quite an honor, and then completed a nephrology fellowship, followed by an advanced glomerular fellowship at Columbia, and now is on the faculty at Columbia, where his focus is mostly on clinical research in rare diseases of glomerulonephritis. And I'm Donald Maloney. I am a professor at the University of Texas Medical School in Houston, the McGovern Medical School. I'm also a Regents Distinguished Teaching Professor of the UT system. I've been focusing for a number of years on evidence-based medicine. I'm co-editor of the Evidence-Based Nephrology textbook. It's now in its second edition. And I've also done a number of Cochrane reviews. My other other research interest is looking at the impact of environmental agents on chronic kidney disease in vulnerable communities, including a large cohort in a Native American population in New Mexico. And I'm very happy to be able to introduce this discussion. So let me turn the podium over to Dr. Sharma, and I look forward to her presentation. One last thing, these are the overall learning objectives for our meeting. Outline the pathophysiology, differential diagnosis, and role of genetic studies in C3G. Discuss current management strategies and unmet medical needs for people with C3G, and then evaluate the mechanisms of action and clinical trials data of investigational therapies for C3G and the future of our treatment strategies. Thank you very much.
Okay. So I'm going to dive right in. And I have no disclosures relevant to this presentation. So what is C3 glomerulopathy? It's a disease process that's characterized by alternative complement pathway dysregulation. It needs a kidney biopsy showing C3 that is at least 2 orders of magnitude higher than the other components, like IgG. It needs to be at least 3 months after an infection, because the most important differential for C3G is a post-infectious GN. So you want to make sure that there's no concurrent infection when you diagnose C3G. And C3G can be classified into dense deposit disease or C3 glomerulonephritis. So I just want to take you a little bit historically, give you a historical background. So C3G is not a new disease. It's been called a lot of things in the past. It used to be called membranoproliferative GN with low C3 in the absence of systemic disease. So this is back in the 60s. And then there were dense deposits identified on the electron microscopy in the 70s. Again, this is just a couple of papers here and there, but just suffice to know that this is not something that we've used a different term lately, but it's not a new disease to begin with. In 2007, it was called C3 glomerulonephritis, and as we know, C3 glomerulonephritis is part of C3G, not the only part of C3G. And then 2013, there was a new name and consensus report, which is called C3 glomerulopathy. So the term C3 glomerulopathy was coined in 2013 consensus report, and they came out with the criteria for C3G. And finally, in 2017, there was a atypical HUS and C3G conclusions from a KDIGO controversies conference that gave some guidance on C3G. So why do we need to define a new disease, right? It's been called a variety of different types in the past. So the clinical course and the glomerulopathology associated with isolated C3 deposition is very heterogeneous. Our understanding of the relationship between complement system dysregulation and glomerular inflammation has improved substantially. I mean, the learning curve for complement and inflammation in the kidney has been very steep, as in the last 10 to 15 years. And most importantly, we have a lot of new treatments that are available now and approved now. So it's very important to identify the group of people who will benefit from this disease. So again, it's a very new age in C3G, and very important to identify what is C3G, what does it entail. So this was the historical classification of C3G, the MPGN, right? So the membranoproliferative GN type 1, type 2, and type 3. So this was based on electron microscopy. And as in all glomerular diseases now, we're turning towards more mechanistic classifications rather than, descriptive classifications. And we've realized that, some of the things that we actually classified as diseases are now like patterns of injury. They can be identified in very many different diseases. So it's important to classify it based on mechanism rather than actual physical description. So MPGN type 1, type 2, and type 3 was based on electron microscopy and location of the deposits. And now we know the MPGN type 2 with mostly C3 deposits, so predominantly C3 deposits, not only C3 deposits, but predominantly C3 deposits, is classified as C3 glomerulopathy, which includes C3GN and dense deposit disease. So, and if you have immunoglobulin deposits, that means the classic complement pathway is activated. So you have to rule out immunoglobulin-associated diseases, including autoimmunity, including infections, etc. So this is a figure from a very recent review paper, and it's a very simplified figure of MPGN pattern on the biopsy. And this is the one that we should sort of take home. So MPGN pattern on the biopsy, we have, is there dominant C3 staining? If there is dominant C3 staining, it's called C3 glomerulopathy. So C3 glomerulopathy, again, and C3G can be classified based on the type of intramembranous deposits. So if it's highly dense intramembranous deposits, it's called dense deposit disease. If none, then it's called C3GN. If there is also immunoglobulin staining, then you can classify it as immune complex MPGN or immune complex GN. If not, then it's TMA. So I want to spend a couple of minutes talking about a couple of things on this slide. So C3G is a lot of times MPGN pattern of injury, but it can also be other patterns of injury, like mesengoproliferative, like endocapillary proliferative with crescents. So MPGN pattern is not the only pattern that's there in C3G, but yes, it's a very common pattern on C3G. The second thing I want to point out is the utility of dominant C3 staining. So we used to say that it should be isolated C3 staining, but we found that based on a number of studies that there were a lot of other immunoglobulins like IgG, like IgM, that were present concurrently in a C3G. It doesn't have to be only C3G. It can be concurrently other immunoglobulins as well, but predominantly C3G. That means it should be 2 orders of magnitude higher than the other immunoglobulins. So this was the consensus report that came out in 2013. So really what it says is that the term C3 glomerulopathy should be used to designate a disease process due to abnormal control of complement activation, deposition, or degradation, and characterized by predominant glomerular C3 fragment deposition with electron-dense deposits on EM. So this is, again, a very simplified classification. You diagnose C3G with the help of clinical criteria and immunofluorescence, and then you classify that into dense deposit and C3G, and based on electron microscopy, whether the membranous deposits are dense versus light amorphous, and the location of the deposits. So I want to just emphasize that C3 dominant glomerulonephritis applies to both C3G and post-infectious GN. So you perform a kidney biopsy in somebody with hematuria, proteinuria, low C3, with probably a concurrent infection. And the pathologist will call you, hey, this is C3 dominant glomerulonephritis. There is no way to distinguish on a kidney biopsy whether this is post-infectious GN or is it C3 glomerulopathy. So you want to make sure that the infection has fully resolved, and you've given enough time. You've given at least 12 weeks for the C3 for the complement levels to resolve before you classify this patient as a C3 glomerulopathy. Otherwise, it's going to be infection-associated GN. So again, it's a C3 dominant glomerulonephritis. It's a pathologic description. It applies to both C3G and post-infectious GN. So what are the clinical features of C3G? It has a very variable presentation, both in adults and in children. So you could have hematuria, proteinuria, nephrotic syndrome. Patients can present with rapidly progressive glomerulonephritis, acute kidney injury, and a lot of times have chronic kidney disease. There's some extrarenal manifestations. Again, C3G itself is a very rare disease. It's an ultra-rare disease, but you can have extrarenal manifestations, including acquired partial lipodystrophy. So basically what that is in the adipose tissue, there is complement deposition, and you have loss of adipose tissue in the upper half of the body. I've never seen it. It's been described. The other one is retinal drusen. So really in the retina, in the basement membrane of the retina, there's complement deposition, and it is also mediated by nephritic factors that I'll talk to you about in a little bit. So there could be extrarenal manifestations of this alternative complement pathway dysregulation outside of the kidney as well. Now, serum C3 is low, and it does not normalize even for a few weeks. So typically about 12, about 3 months, we give patients 3 months for the complement to normalize after an infection. Now, if you've seen patients with C3 and you follow them over time, you will realize that C3 doesn't actually normalize for a very long time in true C3GN. It can take months, up to a year, for C3 to actually normalize on treatment. So, 12 weeks seems like a reasonable sort of target. About 70% children and 30 to 40% adults reach ESRD within 10 years of diagnosis. So again, the prognosis is not good with the current treatment, with the current standard of care that we have. Of course, a lot is going to be coming up in the next few years. Post-transplant recurrence rate, very, very high, 80 to 100%, leading to allograft loss in about 50% of patients. So, not a very common disease, but a very difficult disease to treat with a poor outcome. So this is just a study from Columbia that really shows the clinical features of C3G. So a couple of things to point out. The male to female ratio is about 2:1. The presentation we already talked about, hematuria and proteinuria present in about 40% of patients. There's also nephrotic syndrome, acute kidney injury, and RPGN in patients who have a lot of endocapillary proliferation, a lot of crescents on biopsy. About 20% of these patients will present with an antecedent infection. It could be any infection, so it could be a trigger of C3GN. And a lot of patients will have low C3 at diagnosis. What could be the triggers of C3G? So this study is a little bit old, but really very relevant. So the C3G triggers, a majority of the C3G triggers are monoclonal immunoglobulin, infections, and autoimmune conditions. So again, as I said, autoimmune, the infections can be present in about 20% of these cases. Others could be autoimmune. And monoclonal gammopathy has been recently recognized to be a very, very important trigger of C3G. So any person above the age of 50 years who's diagnosed with C3GN or C3G, for the first time must be we have to rule out monoclonal gammopathy in a patient like that. So what does a kidney biopsy look like in C3G? As I mentioned, kidney biopsy is very variable. We used to think it's only MPGN or membranoproliferative pattern of disease, but it's actually a bunch of things. It could be any pattern, actually. It could be mesangioproliferative, you could see, membranoproliferative, or diffuse endocapillary proliferative with crescents. So membranoproliferative is not the only pattern of injury in C3G. Immunofluorescence is the key. It's really the way we diagnose C3G is with immunofluorescence. So it shows strong granular staining for C3, which has to be at least 2 orders of magnitude greater than the other immunoreactants. So we know all of the other immunoglobulins can be present, but the C3 is the predominant immunoglobulin present. So, IgM is a large molecule, it gets trapped. IgG can be concurrently present as well. And again, does not have to be isolated C3. I think I've made that point a couple of times now. In these 3 figures, you could see, there's a fine granular appearance of the basement membrane. The middle one shows some tubular basement membrane deposits of C3, and the third one is a little bit more coarse. So the patterns can vary, but suffice it to say, there is strong staining for C3 that exceeds whatever is surrounding the C3. So this is just another paper from Columbia back from 2014 that showed that in addition to C3, you can have other immunoglobulins. So C3 is not the only, it's not we diagnose C3G not just based on C3 alone, but the predominance of C3 over the other immunoglobulins. Electron microscopy, it's used to distinguish between dense deposit disease and C3 glomerulonephritis. So dense deposit disease has dense intramembranous deposits, which is exactly like this, and C3 glomerulonephritis is more proliferative, and the deposits there are light amorphous, mesangial, paramesangial, subendothelial, and subepithelial deposits. So the locations of these deposits can vary. Very recently, so just last year from Dr. Sethi's group, we now know that apolipoprotein E is also enriched in these dense deposits and may be a marker for dense deposit disease. So more to come about apolipoprotein E later. I don't want to spend too much time on ApoE right now. So what are the potential challenges in the diagnosis of C3G? So I told you, light microscopy can be very variable. Isolated C3 deposits may be absent, so there's, other immunoglobulins might be present. Important to rule out infection-related GN. C3 dominant glomerulonephritis I already spoke to you about. Subepithelial humps may not be specific for post-infectious GN, so they could be present in other conditions as well. So subepithelial humps does not equal post-infectious GN. So just realize that there's a whole spectrum of findings that you can have in C3G, which are not the ones that are being classically described. And the other thing is that biopsy might change from immune complex GN to C3G and vice versa. So you know that immune complex GN is mostly is mediated by the classical complement pathway, and the C3G is alternative complement pathway. But the switch from alternative to classical complement pathway can occur. And you biopsy a patient one time and they have immune complex GN. You biopsy them 2 years later and they might turn out to have C3GN. So that can also happen. So just be at a low threshold for rebiopsying these patients when the diagnosis is not clear and the infection has gone away. One thing I do want to mention that I didn't put in this here is sometimes you do need pronase digestion to bring out the immunoglobulin when the immunoglobulin is not present. So, and that can also help in making a diagnosis of C3G versus, classical complement pathway activated or immunoglobulin activated GN. So just a couple of seconds about the complement system. So the complement system is the guardian of the intravascular space, right? So it's the first line of defense against all infections. So when you have an infection, so there are 3 pathways that are activated. So this is the classical pathway, lectin pathway, and the alternative pathway. The classical complement pathway is activated in the face of an antigen-antibody complex. The lectin pathway is very similar to classical pathway. Only thing is that it's actually activated by a sugar residue in the bacteria. So, both of them, both classical and lectin pathways actually need a trigger to get activated, whereas the alternative pathway, the difference between classical and lectin and alternative pathways, the alternative pathway has a tick-over mechanism, which means that it is a low level, it's activated at a low level all the time in everybody with a very short half-life, which means it's always active, it's always ongoing. If you need more alternative complement pathway, you make more, but on a low level it is already active. And how does it become active? Is conversion of C3 to C3a and C3b by C3 convertase. So low-level C3 convertase is always present, converting C3 to C3b and C3a. And remember, C3b is the most important molecule in this alternative complement pathway. Why? Because C3b is deposited on the pathogen surface, which marks it for destruction. C3b acts as an opsonant, so it favors opsonization of the bacteria. And finally, the anaphylatoxins, which are C3a and C5a, are also produced. So C3, with the help of C3 convertase, gets converted to C3a and C3b. Now, C3b, with the help of factor B and factor D, piperidin, further contributes to more C3 convertase, and this forms into an amplification loop that keeps going on and on. The normal time this amplification loop lasts, if there is no infection, is about 90 seconds. So it's a very quick hydrolysis of these enzymes, because the inhibitors just come in and they hydrolyze the C3 convertase and it's gone, and then it starts all over again. Now, if you have an infection, you will make more, and the pathway can last a longer time. So the body will make as much as it needs. But the problem with C3G, as you'll know, is that the inhibitory pathways are less and the propelling pathways are more. So there's an imbalance between the two, leading to a lot of alternative complement pathway activation. So finally, the C3 convertase gets converted to a C5 convertase and converts C5 to C5b, and finally C5b to 9, which is the MAC complex that is the membrane attack complex that leads to the insertion of holes in the bacterial membrane and lysis. So there's a very delicate balance between activation and control of the alternative complement pathway, right? So too much activation or insufficient regulation will lead to inflammation, and too much control or insufficient activation makes you predisposed to infections. So, you know, the homeostasis in the regular time is mediated by rare mutations, there's common polymorphisms, there's deficiencies, there's expression levels, there are autoantibodies, environmental factors. So there's a lot of things that are controlling this balance of complement. And in C3G, this balance is towards the left, which is too much activation and insufficient regulation. So coming to what are the genetic and acquired drivers of C3G? So human C3G is primarily an autoimmune disease. It is not a genetic disease, it's an autoimmune disease. Only about 20 to 22% of patients will have genetic factors. We do genetic testing in everybody, and I think that's a very good thing to do, but primarily it is not a genetic disease, it's an autoimmune disease. It is mediated by autoantibodies or nephritic factors that I'll come to. So what are the genetic variants? C3, I told you the C3 is a very important component of the alternative complement pathway. The complement factor H, complement factor HR1, 5, complement factor B, which is about 1%, complement factor I mutations. So remember, complement factor B and complement factor I mutations are, they are the inhibitory pathways. So if there are mutations that are removing the inhibitory effect of these mutations, that will lead to over-activation of the complement pathway. The acquired defects, which are the nephritic factors. Nephritic factors are autoantibodies that stabilize the C3 convertase that I told you about earlier, right? So the C3 convertase is the culprit. The overactivity of the C3 convertase is the problem. So anything that stabilizes the C3 convertase and really prevents it from getting degraded is a big problem. And nephritic factors are one of them. So C3 nephritic factor prevents the C3 convertase from getting degraded or stabilizes it. C5 nephritic factor does the same thing to C5 convertase, and so on. So C4 nephritic factors. There is also anti-factor H autoantibody and anti-C3b autoantibody that can be found. So again, genetic factors in C3G could be gain of function changes in the complement activation pathway, which is factor B and C3. There could be loss of function mutations affecting the complement regulatory proteins, such as complement factor H and complement factor I. So you are taking away the regulation of the complement pathway. Mutations in C3 that impair the ability of complement factor H or CR1 to downregulate C3 convertase activity. So again, the pathways that are activating the complement pathway, alternative complement pathway, are overactivated. The inhibitory ones are underactivated, and the alternative pathway is overactivated. So what about serologic testing? So the serologic testing can be divided into 3 parts, which is specific activation of the alternative complement pathway can be measured by reduced C3, normal C4, and reduced factor B. C3 turnover could be reduced C3, increased C3 breakdown products. So remember that C3 is getting converted now. So increased C3 breakdown products like C3D. And then there's also C5 turnover, which is low C5, increased soluble C5b to 9, and C5a. So a lot of these tests can be done in the lab, or they can be sent out. And a little bit more about acquired causes of C3G. So acquired causes of C3G means nephritic factors that are autoantibodies. So these antibodies will stabilize the alternative pathway C3 convertase, which is C3bb, preventing its inactivation by the complement regulators. So if you look at this figure, the C3BB, this is the C3 convertase. So normally the C3 convertase is inhibited by factor H and factor I. So, and when it's inhibited, it breaks down into C3b and BB. And with the help of these nephritic factors, the nephritic factor is present, this will not break down. So it gets more stabilized, it will act for a longer time. So the alternative complement pathway will just keep going, really. And the C5 nephritic factor are autoantibodies that stabilize the C5 convertase. And this is just a schematic of the same things, sort of blown up a little bit. So you could see that dissociation by factor H, MCP, can happen. And so the C3 convertase gets dissociated when it's not needed. But if you have a C3 nephritic factor, it will actually stabilize that enzyme, and basically it will just keep going. So nephritic factors are a heterogeneous group of immunoglobulins. They bind to different epitopes of C3 and C5 convertases, and they prolong the half-life to different degrees. There's varying resistance against complement regulatory proteins, which is factor H, CR1, etc., and efficiency differs for each regulator. And this is a little bit too much, but it can be prepared independent or independent. We don't need to go into too much detail, but prepared independent C3 nephritic factors can lead to dysregulation of both C3 and C5 convertases, leading to the terminal complement activation. This was a very interesting French study that literally looked at C3 convertases. So really anti-C3b autoantibodies. So nephritic factors, really. So they're looking at what the nephritic factors are doing to the C3 convertase. So how are they acting on the C3 convertase, right? Are they enhancing the formation of the C3 convertase? Are they stabilizing the C3 convertase? Or are they doing both of them? So they took about 27 patients. Out of them, there was a combination of C3G and primary immune complex, MPGN. And they found that 6 out of those 27 were enhancing the formation of the C3 nephritic factors. 3 out of 27 were enhancing the stabilization of the C3 convertase, and 9 out of them had double function. So you can imagine that the nephritic factors that had dual function were worse for the patient, right? So the 5-year kidney survival among those with double function was 70%, as opposed to 100% in patients who had in which the people in which the nephritic factors were only doing one kind of activity for the C3 convertase. So really, nephritic factors are the primary drivers of disease in C3G. So this is sort of just a take-home point. So autoimmune disease, not a genetic disease, but must rule out genetic factors or genetic causes. Monoclonal gammopathy. I can't stress this enough. This has to be ruled out in patients more than 50 years. So the monoclonal immunoglobulins, really, they're acting as nephritic factors. They're literally stabilizing the C3 convertases and turning on the alternative complement pathway. So anti-factor H and C3 nephritic factors. So treatment of monoclonal gammopathy may stabilize kidney function and remission. So if you have a monoclonal process that's going on and somebody is above 50, diagnosed with C3G for the first time, they have to be referred to hematology for a bone marrow biopsy. And sometimes the hematologist may be like, this patient doesn't need a marrow because they're not going to qualify for treatment. But you have to explain that even if this is MGUS, it will be MGRS. It will need to be treated for, 1, the C3G to stabilize, 2, if this patient needs a transplant in the future, the monoclonal, this clone really needs to be treated. So monoclonal gammopathy-associated C3G recurs early post-transplant, and we've seen patients who will recur post-transplant and they were never found to have monoclonal gammopathy before the transplant. And also it turns out to be more aggressive. So really, the people with C3G diagnosed for the first time after the age of 50 need to be ruled out for monoclonal gammopathy. So what's a summary of acquired causes? So I talked about nephritic factors, which are mostly C3 nephritic factor, C5 nephritic factor, and C4, monoclonal proteins, and then there are other autoantibodies to factor B, factor H, C3b, etc. So these can be tested for. So tests that are recommended in all patients with C3G. So C3 and C4, it's part of routine laboratory testing. So low C3 and normal C4 indicates alternative pathway activation. C3 nephritic factor, so this could be a send out. This is not normally tested in hospital-based labs or clinic-based labs. So it is associated with C3G, but just the mere presence of nephritic factor doesn't mean much. It has to be clinically correlated. So if you have a patient with C3G and you have a C3 nephritic factor, it might correlate with the disease, but the correlation with the disease course is unclear. So we're not 100% sure how to use that level yet. Serum factor H, which is factor H deficiency, is associated with C3G. Serum paraprotein detection, determine if paraprotein is a cause of uncontrolled alternative pathway activation. And this complement factor HR5 mutation, this is a well-characterized cause of C3G, not here in Cyprus, but screening can be clinically informative. So really, any patient who comes in, young patient, they should be ruled out for CFHR5 mutation. And tests that should be considered on a case-by-case method. These are a lot of tests, and all the labs may not do all of them. Some may do some other testing. And usually, as you know, genetic testing is part of a standardized test. So all the tests that are done by a particular lab are done at the same time. But serum factor B can be reduced in uncontrolled AP activation, serum factor 5, markers of C3 activation, markers of C5 activation, anti-factor H autoantibodies, because those patients need to be treated a little bit differently, anti-factor B autoantibodies, and then mutation screening of complement regulatory genes, including complement factor H, CFI, CD46. So a lot of information here, but just got to synthesize it and use it in the right sort of patients. So a few academic centers and a bunch of private labs run all these genetic tests, and usually they're part of a panel. So I just put a panel up there that's usually tested if you send off a panel like this. And the variants are classified into 5 categories, which are pathogenic, likely pathogenic, variants of uncertain significance, likely benign, and benign. And all of these genetic tests have to be carefully interpreted by a genetic counselor and you, so that the patients can be guided correctly and the treatments can be begun. So if any of the changes are detected, they must be rigorously analyzed to determine whether they represent disease-associated changes. So the presence of something does not mean that it's actually clinically relevant in this patient. So the demonstration that the novel variant segregates with disease in familial cases, the lack of segregation would normally indicate that the variant is not disease-associated. The demonstration of rarity of the disease-associated variant or mutation in a large population database, in addition to ethnic-specific databases, right? So it's not that this mutation is commonly present in, in normal population as well. And then the demonstration that the mutation affects protein function. This is a very hard thing to do, and not a lot of academic centers or labs will do functional testing for these proteins, but if you can get them done in the right patient and refer them to the right place, that can be very important. I don't know if this is visible. So this is, I think, one of my last slides. So if you have C3G on biopsy, you institute supportive therapies. You rule out infection-related GN, right? So IRGN should be excluded. If it's not excluded, you treat the infection. So if there's an active infection that's present, you treat the infection. And if no improvement after eradication of the infection, you should consider a rebiopsy in C3G. Now, not every patient needs a rebiopsy. If you have a C3 dominant glomerulonephritis, you have an active infection. Now it's 6 months out, the C3 is still low, the patient still has hematuria, proteinuria. It is very likely to be C3G. But you can decide on a case-by-case basis. Then you have to exclude dysproteinemia. Monoclonal protein is present or not. If it's present, then refer to hematology. If it's not present, then you check genetics. You check genetic C3 nephritic factor, soluble C5 beta 9, refer to the expert center, and consider enrollment in a clinical trial. We're going to talk a lot about clinical trials and new drugs very shortly, and you consider a proximal complement inhibitor. Again, we're going to talk about that. And I'm not going to go to the rest of the flow chart because we'll talk a little bit more about it in a few seconds. So what are the take-home points? We got to review the clinical data and the biopsy findings for C3G. So I talked about the different patterns of kidney, patterns of light microscopy, immunofluorescence, and electron microscopy. You perform complement studies, including genetic testing, and rule out paraproteinemia in older individuals. And then you synthesize that information, right? So you synthesize everything together. You integrate the clinical, genetic, biomarker, antigenic, and structure function data to find the etiology, to assess the risk of progression and recurrence, and make treatment decisions. So everything has to come together at the end and for a decision on who to treat and what to treat them with. So that is my last slide. And I think we'll do questions at the end.
So now I've got to back to sessions. No, I've got the wrong one. Thank you. Great. Okay, so I'm going to follow that very comprehensive review of both the pathophysiology of C3 glomerular C3Gs and the strategy to diagnose them, with some reinforcing what you've already learned by presenting some cases here. So that we're going to go through that. I have no relevant disclosures to this presentation. You can see I'm on some speakers bureaus. And I'm going to try to reinforce what you've learned about the recognition and diagnosis, clinical presentation, signs and symptoms. I have two cases which we're going to review their biopsies, and then I'm going to talk a little bit about the current state, and I use the word current in quotes, of therapeutic approaches, because I'm going to take us to maybe a year ago, before new therapies that are in clinical trials were being advanced. And I'm going to review the data that supports those older therapies, and then we'll have Dr. Wooden talk about the newer therapies that are emerging. I want to re-emphasize that C3Gs, both types, glomerulonephritis and dense deposit disease, are very rare diseases, but they do occur, and they are probably well under-recognized, and I will make some comments on that. And if we're going to advance the science and also the care for our patients, we need to investigate new strategies, and so that patients that are identified with C3G should be, if at all possible, referred to clinical trials, or potentially soon treated with the newer strategies. So early diagnosis and proper diagnosis is really important. It provides individuals with clear understanding of prognosis with current treatments. It provides baseline expectations, and those are going to change dramatically. Now, one thing that we could amplify on, I'm not going to, but depending on which is the etiology of the glomerulonephritis, the prognosis is potentially shifted, and some of these antibody tests and other specialized tests that would occur in a center will help us be better in prognosticating the current state of their future kidney function. However, with the new treatments, we still have to determine how these new treatments fit into the various subsets of this disease. And of course, understanding the pathophysiology and the pathology allows us to best evaluate and target newer therapies currently under investigation. And this, again, will be discussed by Dr. Wooden at the end of my presentation. I just show this slide just to remind us that there are a number of glomerular diseases that are mediated by complement abnormalities, and the C3Gs are a unique part of that spectrum, but as we've already heard, they're classified by predominance at least twofold greater than any other staining or unique staining alone, and that's how they used to be identified. So the common features of presenting signs and features of this disease in virtually everyone is either hematuria or proteinuria. And proteinuria is very common but not universal in these patients. Other findings could include hypertension, peripheral edema, low C3 levels, and kidney dysfunction. Low C3 levels is not done on every one of these patients, as I know from clinical practice, but it is often associated with the underlying diagnosis that we're talking about today. They may also exhibit, but it's not required, the unique features of C3G that you've already heard from Dr. Sharma. And the mean diagnosis currently in clinical cohorts is 21 years. So 61% of the cases are identified in children. And I think this may be a surveillance bias or effect, because in adults who have proteinuria in a little bit of an unusual course, and maybe diabetes or hypertension, they are often not biopsied. I would wager that many of you who treat adult patients do not biopsy everyone who comes into your office with persistent proteinuria. And so I think that C3Gs are probably being underdiagnosed in adults. And that may give us an opportunity for earlier and better diagnosis in this segment of the population that would allow us to utilize the newer strategies. The incidence and prevalence of the disease from these kinds of studies is somewhere between, incidence is somewhere described as between 1 to 3 per million. And then you can see from 5 to 140 per million for prevalence. That's, again, an issue of how these cases are collected and enumerated. So, but it is in any case a very rare disease. We've already heard that about 50% of these patients will progress to end-stage kidney disease in a little over 10 years. And the rate of progression, again, is dependent on the GFR at diagnosis. So if you have a higher degree of renal insufficiency at diagnosis, it means you've already lost the opportunity to treat more effectively, and they're more likely to progress more rapidly. It also may indicate a more aggressive disease state. And then the presence of C3 nephritic factors that we've learned about and other factors may influence the prognosis. And then this disease occurs commonly in kidney transplants. And you already heard the numbers in Dr. Sharma's presentation, but it is very common in transplants. And in transplants, it does sometimes appear to have a different natural history. It may be even more aggressive when it reoccurs in transplants. So if we're going to transplant these patients to provide them with treatment for their renal insufficiency, we should, if at all possibly, control the disease state. And common symptoms, again, that may be very nonspecific include fatigue, weakness, anxiety, and depression, and this latter usually occurs after diagnosis, pain and discomfort, and difficulty with normal activities of daily living. So these are very nonspecific features, and suggesting that maybe we should be more aggressive about it, trying to diagnose patients who may have this disease. So I'm going to start with a patient. KF is a 48-year-old man with kidney failure. He presents with a history of consistent with acute kidney failure, has a prior history of type 2 diabetes, schizophrenia, substance abuse, alcoholic cirrhosis of the liver without a history of hepatic encephalopathy or acute liver damage, mesenteric ischemia, partial colectomy, and colostomy. So he's got a lot of diseases, and I would wager that virtually any of you who saw this man in your clinic would say it was due to one of these other diseases that I've already described was cause for his acute kidney injury. And in fact, that's what occurred. His last comprehensive evaluation about 1 year previously, he was noted to have a microscopic hematuria attributed at that time to a traumatic catheterization, and a creatinine of 1.4 milligrams per deciliter, a GFR of 62, and a UA at the time had trace proteinuria, but an albumin to creatinine ratio at a minimum or a protein to creatinine ratio were not obtained. On examination, he did not have any evidence of diabetic retinopathy. So diabetic nephropathy was less likely in this patient. But he wasn't really evaluated very stringently. It was just followed, like many of these patients are followed for some time before the diagnosis is made. He presented again now with generalized malaise, increased nocturia, some peripheral edema, and an elevated blood pressure. His physical examination was unremarkable except for 1+ pretibial edema. He appeared to be euvolemic. His retinal examination was on routine physical exam. Did not demonstrate evidence of diabetic retinopathy. But again, this is just a house staff member looking with a ophthalmoscope, so it's not a comprehensive retinal exam. His laboratory studies now showed a creatinine of 2.7. Now his GFR was 28. So he's gone from 62 to 28 in about a year. We don't know whether it's acute kidney injury or more chronic or progressive kidney decline. His UA shows 3+ protein, 2+ blood, 12 to 15 red cells, and a UPC of 2.4, which I indicated at the end. His MITting team ordered a series of studies, including liver functions, ANCA, ANA, CRP, and a 24-hour urine for protein and creatinine clearance. He also got a UPC as SPEP and a UPEP and a hepatitis serologies, HIV, etc. It's kind of typical for an acute kidney injury patient coming into the hospital that gets a whole lot of screening tests, many of which are probably redundant or not helpful. But so you've got a question here. I think we get to, on the next slide, to try this question. While you're waiting for the results of the serologies, which of the following strategies should you consider for your next step? Order more serologies, including complement, order serum complement levels, including C3, and arrange for kidney biopsy with appropriate staining. Follow the patient for 90 days to confirm persistence of the hematuria and proteinuria. Of course, he also has kidney failure of some degree, and attribute his kidney function failure to diabetic nephropathy and begin discussion of ESRD management, and suppress proteinuria with initiation of RAS blockade and or an SGLT2 inhibitor. So I think the next slide lets you poll everywhere to address this question. I'll give it for a minute or so, and then we're going to go on. Okay. So everyone said, get a C3 and do a biopsy. And I think that the point has been well made by Dr. Sharma in the beginning. Biopsies are critical to this diagnosis, and there's no contraindication to doing a biopsy because there may be other causes for acute renal failure or more chronic kidney failure that we're missing, but rapidly progressive renal failure if it's chronic. So C3 was drawn on admission and was returned as a low level. Other serologies were with normal limits. This would support, again, the possibility of C3G. Cannot exclude the possibility of post-infectious complement-mediated glomerular injury. Timing of the AKI could not be established. However, the biopsy did show a membranoproliferative glomerulonephritis-like lesion with C3-only deposits. So this is a 49-year-old man with C3, pure C3, consistent with C3 glomerulonephritis, moderate arterial sclerosis, and moderate to marked hyaline arterial sclerosis, ultrastructurally thick glomerular basement membranes consistent with some diabetic nephropathy. So he had a component of diabetic nephropathy likely. So let me go ahead and show you the biopsy results. So this on the left is an H&E stain that shows mesangial and endocapillary hypercellularity in the glomerulus. And on the right, you see now the silver stain, which again shows a segmental basement membrane double contour. My pathologist and I, looking at, oh, I didn't mean to go forward. Sorry about that. Looking at this slide, did try to find some double contours, but there may be, but that's what you would expect with a normal silver stain in a membranoproliferative disease. And she assured me that on another slide, she did easily see contours, the double contours, train tracking, as we used to call it. And this is a trichome strain. There is a interstitial fibrosis, and what you see, there's a lot of blue stain on here. This blue stain up here is a blood vessel cut on FOS, so that's not really where you don't want to look at these places. But here you see the blue staining, so you've got fibrosis there. So this suggests this is an active lesion. And I apologize that my pathologist likes to do black and whites of the immunofluorescence because they're easier to reproduce in reports, et cetera. So this is what we have. But what you can see is very prominent C3 mesangial and capillary glomerular deposits on this slide. Otherwise, it should be green immunofluorescence. IgA, IgG, and IgM, not showing the last one, are completely negative. And kappa and lambda were negative. A UPEP with immunofixation did not show any evidence of myeloma proteins. And this is two EMs. The one on the left shows a lower power, and what you can see is very prominent dense electron deposits with thickened glomerular basement membranes due to diabetic nephropathy, also shown here, but you've got the dense deposits from the C3GN. And on the right is a high power of the mesangial section of this same glomerulus, and you'll see dense deposits in the middle here from the staining. And this is less prominent that you might see in dense deposit disease, as we've already learned from Dr. Sharma. So the biopsy, again, specimens show these chronic and acute membranoproliferative GN changes with C3 dominant deposits. And I'm going to skip through reading the complete description here, but to exclude the possibility of a masked epitypes of monoclonal immunoglobulin deposits, immunofluorescence was repeated on a protease-treated paraffin section. And that will allow you to say that there was no evidence of heavier light chain deposits. So this is not, even though he's 49 years of age, and 50 is a pretty arbitrary cutoff, he should be evaluated for gammopathies that might be participating in this disease. So another question for you all, let's go right to this. With available treatment strategies prior to 2023, what treatment should be considered? I don't have the answer on the next slide. We're going to talk about it a little bit. Okay, so because I've lost let me go back. A and C is going to be supportive therapy and eculizumab. Okay. So the majority of people said using supportive therapy, which would be essentially RAS blockade and eculizumab. And I'm going to review the two other therapies here after I talk about the next case. So, okay. So in this case, however, KF had demonstrated significant clinical progression in the presence of non-nephrotic range proteinuria, but without significant active proliferative changes in the biopsy. He did have a lot of fibrosis. He was treated initially with RAS blockade for 3 months with a reduction in proteinuria, and with a UPC now of 1.6, it was not below 0.7 or 0.5. And clinically, he continued to progress with further decline in GFR. MMF was added to his regimen and was reported to result in some further reduction in the UPC, but he continued to decline in his GFR. And let's now, in a bit, we'll review MMF, the evidence for MMF and for eculizumab. Okay. So this is my second case. This is Miss S. MS is a 61-year-old woman, 4+ proteinuria. MS is, again, this woman with a history of rheumatoid arthritis now. So she has some kind of inflammatory disease for which she is being treated with methotrexate for more than 14 years and with controlled RA symptoms, but a persistent positive rheumatoid factor. But she does not take nonsteroidals on a regular basis. She's been hypertensive for 5 years, successfully treated with a calcium channel blocker. She presents now with peripheral edema, a serum albumin of 2.5, 4+ protein on UA, and 2 to 5 red cells on high-powered field. So the last UA 6 months ago did not show any protein by dipstick. Her UPC is now 4.5. So she's got the nephrotic syndrome. CBC is notable for a hemoglobin of 34 and an MCV of 84. She's reported increased fatigue, but that she attributes to her RA and some weight gain. A renal biopsy, fortunately, is performed. So before considering C3G, what causes of her nephrotic syndrome, as a cause of her nephrotic syndrome, what other diseases need to be excluded? The choices are infectious GN, monoclonal gammopathy, A and B, or none of the above. And I think you should all get this one right from what you've learned from Dr. Sharma. Okay. Well, despite the fact that she didn't have any clear antecedent history of an infection, I think you still should be cognizant that you want to exclude that. But also, she's 61 years old, and so we need to exclude a monoclonal gammopathy of some type. This is her biopsy, H&E stain on the left and the PAS stain on the right, and you see very typical patterns of membranoproliferative disease and a very prominent staining of membrane on the PAS stain. This is the trichome stain. Now it shows an interstitial fibrosis. My pathologist and I the other day looked at this again just to be sure that the number that we were quoting here was correct, and she claimed she estimated about 30%. So there's a lot of fibrosis, not as prominent as the previous one, but certainly one that would be amenable to treatment if we were going to do that. This is her biopsy. Immunofluorescence is strongly positive for C3, but it was negative for immunoglobulins in both frozen and protease-treated paraffin sections. So C3GN deposits, CC glomerular and mesangial capillary deposits on the left, and again on a different view on the right. And our C1Q was negative, and our C4D was also negative. And IgA, IgAG, and IgM were all negative for staining. This is her EM, and this shows clear dense deposit disease. You see endocapillary and intramembranous deposits on the EM, but you also see these clear deposits that are, didn't mean to do that, guys. And I'm in the wrong view for myself, but not for you. So you see these deposit in the, and it's not showing up there. Okay. We'll get there. Oh, we're back in the proper view. So you'll see, but this isn't the right slide. I apologize. I was trying to use the arrow to show the clear intramembranous, mesangial and intramembranous ribbon-like electron-dense deposits that makes this then C3 dense deposit disease. And again, I showed you after the previous one that this was, the kappa and lambda were negative, and the association between myeloma and or myeloma-like MGUS and other kinds of monoclonal gammopathies and dense deposit disease is pretty prominent. It's very common, but there was none on the staining here. So I'm going to switch for just a few more minutes to some considerations of therapy, and I'm going to use two sources to document the types of therapy that one would consider at the time that these biopsies were done. This is from the KDIGO Consensus Conference, or Controversies Conference of 2017, that then was translated into the KDIGO recommendations in the update on the glomerulonephritis KDIGO of 2021. So what you can see is that for all patients, it's suggested that one include optimal management of conservative management of blood pressure and using optimal RAS blockade. For moderate disease with urine proteins of greater than 500 for 24 hours or moderate inflammation, repeat biopsy, recent increase in serum creatinine, recommendations in this case would be prednisone and meclofenamide mofetil. And then for more advanced disease, they recommend that you might consider eclosumab. So eclosumab I will talk about in a minute, but let's turn to the evidence that supports these recommendations. So this is the overall now in the KDIGO 2021 optimal treatment strategies for C3G using currently available therapeutics has not been established. good statement. Expert opinions has encouraged the usual supportive therapy as well as the use of immunosuppression in the setting of moderate to severe disease, defined as such, greater than 2 grams of protein as one of those part of the definition. This opinion is based primarily on 4 retrospective cohorts and on an extrapolation of data from other non-related proliferative glomerulonephritides. It's well-controlled, randomized controlled clinical trial data are not available. In the absence of myoclonal gammopathy, C3G patients with moderate to severe disease should be treated initially with MMF and glucocorticoids, and then if this fails, eclusumab should be considered. That's their recommendation. So, and this is just a repeat of that. Let's go on. So this is my summary of the clinical trials that have been done to support the use of MMF. And what you'll notice by these is that they are all cohorts and mostly retrospective cohorts, looking at centers that have a number of these patients that have been collected into a database and then looking back in time at where they started and what their outcomes were. There was one prospective cohort that was from the Spanish group that showed that stated that there was greater probability of remission seen in patients treated with MMF plus steroids versus steroids alone or steroids plus other immunosuppressive drugs, which was a collection of calcineurin inhibitors, etc. And this was probability because the number of patients were small and this was not a randomized trial. Bombeck and colleagues from Columbia did a retrospective cohort, which was much larger, with 87 C3GN patients and 24 dense deposit patients with differing prognosis. Remission rates appeared similar for C3GN patients treated with MMF versus conservative therapy. Treatment choice is probably influenced by pathologic classification of C3GN because this was not a prospective trial. This was their experience and reporting of their experience. So the risk of bias in all these trials is pretty high. The best news about our newer treatments is that we're having real randomized controlled clinical trials so that we can hang our heads on that. And then there's the last two are also showed in a retrospective chart review a high number of responders in those receiving MMF, but if they came off of MMF, they're more than 50% relapse pretty rapidly. And then in the last study in 2019, no difference was seen in an Irish and a London English cohort with any immunological therapies that were used, and 29% in this group progressed to ESRD within 28 months, so it was a pretty aggressive group of patients. So this is very mixed therapy even in these studies that are all observational studies. Some show potentially some benefit and some show, and the last one shows no difference in immunosuppressive therapies. And so I would argue that this does not support the KDIGO's recommendation to use them, especially if we have things that are shown to be more effective. And then this is the data on eclusumab. So the bottom line from KDIGO is the benefits of terminal complement blockade with the anti-C5 monoclonal antibody eclusumab remains unestablished. And this just again shows a number of case reports as well as a few. The first study that was by the Columbia group was an open label proof of concept efficacy and safety trial where they actually looked at 6 patients, 3 with C3GN and 3 with C3 dense deposit disease. And their quoted response was there was a variable response to treatment. Notably, 3 of the patients in this proof of concept trial were recurrent patients with recurrent disease and post-transplant, and which may be a different entity. The next 4 listed here are either case reports or case series, and the last case series from 2018 showed, again, variable outcomes with the eclusumab. There seemed to be a few patients, especially in the case reports, that responded dramatically, but otherwise there was not much benefit demonstrated. target. So key takeaway messages, C3GN and C3 dense deposit disease are probably quite underdiagnosed, especially in adults. Thus, patients of any age who present with hematuria and or proteinuria and negative serology should be evaluated by kidney biopsy to interrogate for rare diseases, especially those as robustly proven and novel targeted therapies become available. A full explanation with evaluation with specific probes for C3 nephritic factors, etc., should be considered, as they may importantly inform the optimal therapy and expectations from treatment. Traditional supportive therapy and immunosuppressive therapies have limited success in slowing the progression of subjects to C3G with C3G to end-stage kidney disease. Now, new robustly treated treatments that have been tested, exploiting our understanding of disease pathogenesis, will importantly address an important unmet need. And early diagnosis likely to be the key to maximally exploiting the full long-term potential for these new therapeutic approaches. And with that, I'm going to turn the podium over to my the last speaker. And you are, let's see, I've got too far along. Future, here we go.
I won't do a good job presenting them. Biopsies.
Yeah, no. All right, thank you very much.
Thank you. Thanks, Dr. Maloney. Everyone can hear okay? Very good. Well, my name is Ben Wooden, and I'm going to be rounding out our presentation today with a talk on the future landscape of treatment in C3G, an update on investigational therapies. And as many of you are probably aware, the landscape has changed quite a bit in the last 2 or 3 weeks. And I think it'd be fair to say that the future is now in C3G. No financial disclosures. Of course, I will be discussing investigational therapies and off-label uses. And these are my learning objectives. So to start with, I think it's important to just ask the question of what is the proper target in C3G? We've heard from Dr. Sharma and Dr. Maloney about the pathogenesis of the disease and some cases illustrating the difficulties with our currently available treatments and their suboptimal responses when we treat patients with conventional immunosuppression and terminal complement blockade. And I think the reason for this is simply that those treatments aren't getting at the root of the problem in C3G and aren't hitting the primary site of dysregulation in the disease, which is the proximal portion of the alternative pathway. And Dr. Sharma covered this concept eloquently. I'll give just a very kind of brief overview of data supporting that assertion that it's the proximal AP that's the site where the action is. First of all, just the fact that the histopathologic definition of the disease is deposition of C3, right? A key component of the proximal AP. C3 nephritic factors, which stabilize the C3 convertase in the alternative pathway, are present in many patients with C3G. And the genetic causes of inherited forms of C3G affect genes coding proteins that are involved in the proximal portion of the alternative pathway. There are also some interesting animal data in models of C3GN showing that blockade of the terminal complement pathway, C5, ameliorates the disease but doesn't eliminate it, whereas blockade of proximal AP components does eliminate the development of C3GN. So if the proximal AP is where we should be targeting, what specific components are going to be the best targets? And there are a number of options. Probably the most obvious is C3 itself. And this is attractive because C3 is involved with the entirety of the alternative pathway. From the very beginning, the tick over mechanism of activation of C3, or of the alternative pathway, but also it's a key component and substrate of the C3 convertase. It's also a component of the C5 convertase in the alternative pathway. And it also serves as a substrate for the convertases in the classical and lectin pathways. So targeting C3 makes conceptual sense. Complement factor B is another attractive target because it is, in its activated form, a component of the alternative pathway's C3 convertase, which again is involved in the activation step and the proliferation of the cascade through the AP. Factor D, the protease that cleaves factor B into its activated form, is another potential target. And there was a drug that was tested in C3GN, an inhibitor of factor D called danicopan. I'm not going to touch on it further in the talk, but unfortunately in its phase 2 trial, it didn't meet its primary endpoint. And it seemed like probably that was because the dosing wasn't adequate and they didn't achieve sustained inhibition of the alternative pathway. But as things stand now, that drug's not currently in development for C3. And then finally, factor H, it would be a little bit of a different target because unlike the others, it's a negative regulatory component of the AP. But there is a drug in development that has a mimicking component of factor H with the idea that it would inhibit the proliferation through the alternative pathway by targeting the C3 convertases. So here I've listed the complement inhibitors that either are or have been recently in testing, in clinical testing for C3G, ordered by their specific target. Oops, no, you don't see that. Ordered by their specific target, and then indicating whether they target a component in the proximal alternative pathway. There are a couple down here at the bottom that don't, avacopan and narsoplimab. I'm not going to discuss those further in today's talk. And then noting their stage of development and whether they have an FDA approval for use in C3G. And for the remainder of the talk, I'm going to focus on the two drugs that have progressed to phase 3, then actually completed phase 3, pegcetacoplan and iptacopan. And we'll start with pegcetacoplan. So pegcetacoplan, and I'm sometimes going to call it PEG because a 5-syllable word is a little bit much to say 30 times. It is a kind of a unique drug. It's a cyclic peptide that targets C3 and C3b and binds them and prevents their participation in the complement cascade. It is actually already approved for use in other indications, in paroxysmal nocturnal hemoglobinuria, or PNH, and geographic atrophy, where it's administered intraocularly. For systemic use, it's delivered subcutaneously. And like other complement inhibitors, it requires vaccination and prophylaxis against encapsulated bacteria. So this is a figure from the PNH literature, but I've included it because it does a nice job of illustrating a couple of things. First of all, it shows that pegcetacoplan, by binding to both C3 and C3b, inhibits steps all along the alternative pathway cascade, from the very beginning of the activation step through the C3 convertase function. And then because C3b is a component of the C5 convertase, down to the terminal complement pathway as well. So this drug would be expected to inhibit both proximal AP and terminal complement activation. Second, they I think just did a nice job in this figure of demonstrating the role of the alternative pathway as this amplification loop. And that's because C3b, which is a product produced by the C3 convertase, is itself a component of the alternative pathway's C3 convertase. So any C3 convertase that's producing C3b, if there's also active factor B around, will produce the alternative pathway's C3 convertase and amplify the complement response. And this is probably the alternative pathway's main function, regardless of which pathway was initiated at the beginning of the complement activation, the alternative pathway will amplify that response. And then finally, this figure, again, I think just does a nice job of showing that both the classical and the lectin pathways, because they're C3 convertases, even though they don't incorporate 3B, they use C3 as a substrate. So pegcetacoplan would be expected to have an inhibitory effect on those pathways as well. So a pretty comprehensive inhibition of complement as a whole. All right, so for PEG, moving on to the clinical trial data, we have 3 trials to discuss, 2 phase 2 trials and 1 phase 3. They broke up their phase 2 trials into native kidney disease and post-transplant recurrence. And I'm going to go kind of quickly through the phase 2 data just in the interest of time. So first of all, the phase 2 trial in native kidney disease, this was called the Discovery trial. It was actually originally intended to enroll patients not just with C3GN or C3G, but with other primary glomerular diseases as well. But they had poor enrollment for the other diseases and wound up reporting on efficacy data just for C3G. It was a small trial. 7 patients were included in the intention to treat analysis, single arm, open label. They did include some older adolescents, and inclusion criteria also included a UPCR cutoff of 3/4 gram and an EGFR of 30 or greater. These are going to be pretty similar inclusion criteria for all of the trials that we look at today. The proteinuria usually is a little bit higher, about 1 gram. Again, like the other trials we're going to see, they had a run-in optimization phase where patients had to be on stable doses of antihypertensives, kind of supportive therapies, and immunosuppression. They did allow patients to be on non-complement inhibiting immunosuppression, mostly steroids and MMF. And they were treated for a total of 48 weeks, and their primary outcome was proteinuria reduction compared to baseline. And they saw in the intention to treat analysis group a 50.9% reduction in proteinuria after the 48-week treatment period, which corresponded with about a 2-gram reduction in overall proteinuria. And in the per protocol analysis, there were 3 patients who had less adherence to the treatment over the course of the study. It was a 65.4% reduction. Serum albumin also improved. EGFR was stable over the course of the trial. And mechanistically, they saw, as would be expected, an increase in serum C3 and a decrease in the soluble membrane attack complex, which is just confirming that not just proximal AP is inhibited, but also terminal complement. And the side effect profile was not concerning. So the second phase 2 trial for PEG was looking at patients with post-transplant recurrence. This one was again structured a little differently to Discovery. It included patients not just with C3G, but also with primary immunocomplex MPGN. And this is based on the idea that those 2 diseases are probably not as different as we think in terms of their underlying pathophysiology. This was, it was actually a randomized trial. There was a small standard of care arm with 3 patients compared against 10 patients who were randomized to receive pegcetacoplan. And it was pretty short, it was 12 weeks. They had a different primary outcome because transplant patients tend to not have as high of baseline proteinuria. So instead of using proteinuria as the primary outcome, they used a histopathologic criterion, which was the degree of reduction in C3 staining on repeat biopsy at 12 weeks. And they did show that the PEG-treated patients had a reduction in C3 staining. 50% of the patients had a 2 order of magnitude or greater reduction in the staining, and 80% had at least a 1 order of magnitude reduction. They also looked at the C3G activity score, and in 80% of patients, that was reduced by at least 54%. They did report on the proteinuria reduction, and in the patients who had a baseline proteinuria of more than 1 gram, they had an overall 54.4% reduction in proteinuria at the end of the trial. And again, there was stability of kidney function and kind of concordant mechanistic data to expectations. And again, it was well tolerated. So on the strength of these data, the drug was progressed into phase 3, which was called the Valiant trial. And these data are not yet published in manuscript form, but were presented at the 2024 ASN in an oral abstract. And this is the summary of those data. So again, a phase 3 trial. It was randomized, double-blind, placebo-controlled. This trial did enroll adolescents as well as adults, and it was a pretty substantial fraction of the patient population that was between 12 and 18 years of age. Could be both native disease and post-transplant recurrence. We'll see it was mostly native. And again, can be both C3G or primary immunocomplex MPGN. And they were treated with either PEG or placebo. These are some notable baseline characteristics. It was 124 patients, so a decent-sized trial, especially for a disease this rare. It was mostly C3G. It was about 3/4 C3G, with the remaining patients being IC-MPGN. And only 7.3% were post-transplant patients, so the vast majority were it was native kidney disease. In terms of baseline EGFR and proteinuria, these patients had pretty preserved kidney function at baseline. So the inclusion criteria was, again, just an EGFR of 30 or above, but the baseline EGFR was around 80 mLs per minute, a little bit higher in the placebo group than in the PEG treatment group. However, both groups had quite significant baseline proteinuria, nephrotic range or near nephrotic and placebo. And so again, just to bear in mind when we're looking at the results, the placebo group was perhaps a little bit milder disease than PEG, but they were both certainly in the same ballpark. And these were their endpoints. So this was a 6-month trial. The primary endpoint is, again, degree of proteinuria reduction, UPCR change at 6 months compared to baseline. They had a number of secondary endpoints. First, a composite renal endpoint, which was a combination of at least 50% reduction in proteinuria with less than 15% decline in EGFR. So basically preserved kidney function with a decent reduction in proteinuria. They looked specifically just at that subset that got the 50% proteinuria reduction. And then they had some histopathologic data as well. In the adult patients, at least, they received biopsies at the 6-month mark, repeat biopsies. And then finally, EGFR change. And here are the results. So for the primary endpoint of proteinuria reduction, at 6 months, the PEG-treated patients had a 67.3% reduction in proteinuria compared to baseline. And compared against the placebo group, which was actually a little bit higher, there was 3.2% increase. So this was a statistically significant decrease in proteinuria in the PEG-treated group. And in the oral abstract, I was presented by Dr. Carla Nestor, and she showed this figure, which I think does a really nice job of breaking that already impressive result down further, showing the change in the proportion of patients with different degrees of proteinuria. So at baseline in the PEG-treated group, blue is less than 1 gram per gram, white is 1 to 3 grams per gram, and gray is more than 3 grams per gram. This was baseline. And then at the 26-week mark or 6-month mark, this was the breakdown. So basically, a much higher proportion of the patients were less than 1 gram per gram of proteinuria, and a much smaller proportion of the patients were greater than 3 grams per gram. And this is the comparison in placebo, where the changes are not as marked. In terms of the composite renal endpoint of preserved EGFR with at least a 50% reduction in proteinuria, 50.8% of the PEG-treated patients achieved that endpoint compared with 3.3% of placebo, statistically significant. 61.9% had at least a 50% decline in proteinuria. In terms of the histologic changes, the activity score was not statistically significant between the two groups. The point estimate favored PEG, but it was certainly not statistically significant. But the degree of reduction in C3 staining on biopsy was significantly different, with a much greater proportion of patients achieving a 2 order of magnitude or greater reduction in PEG versus placebo. And then finally, showing the EGFR slopes in the groups over the course of the trial, the PEG-treated patients had a decline of negative 1.6 mLs per minute as compared with negative 7.9 in the placebo group. And in terms of adverse effects, the treatment was overall well tolerated. The treatment emergent adverse events were similar between the two groups. There was one death in the PEG group, which was due to COVID-19, and at least in the abstract presentation was thought to not be related to, or judged not to be related to the treatment. And importantly, there were no meningococcal infections. And a press release went out just very recently that pegcetacoplan was approved for a priority review designation by the FDA, and there's an action date reported as July 28th. So hopefully that means that we'll get an answer on the drug by then, within a few months. Okay, so now we'll move on to iptacopan. Iptacopan is an oral agent, and it targets factor B in the alternative pathway, which, if you remember, the activated form of factor B is incorporated into the alternative pathway's C3 convertase. So a blockade of factor B would be expected to inhibit the alternative pathway from very high up and all the way down through the terminal cascade, because activated factor B is included in the AP's C5 convertase. Iptacopan is already approved for use in PNH. Also, it's approved in IgA nephropathy. And as of about 3 weeks ago, it's now approved for use in C3 glomerulopathy. Like pegcetacoplan and other complement inhibitors, it requires vaccination against encapsulated bacteria. For iptacopan, we have two trials to go over. A phase 2, which combined native and transplant recurrent disease, and then a phase 3, which was native disease only. And both of these trials are purely C3G, no immunocomplex MPGN. So for the phase 2 trial, this was also an open label, single arm, fairly small, 16 patients in the native cohort, 11 in the transplant cohort. Patients were treated for 84 days, so just about 3 months. And the endpoint was different between the two cohorts. For native disease, it was proteinuria reduction. For kidney transplant, post-transplant recurrent disease, it was a change in the deposition of C3 on the follow-up biopsies. And they did show in the native group a 45% reduction compared to baseline in proteinuria. And in the transplant group, a 2.5 fold or 2.5 point difference in the C3 deposition, which was based on the scoring, the 0 to 3 plus scoring on the biopsies. C3 levels normalized in most patients, supportive mechanistic data, and other markers of complement activity, including soluble membrane attack complex, were also normalized or decreased in treated patients. Again, just confirming that this drug, although it targets a proximal AP component, it does feed forward to inhibit activity of the terminal complement as well. And iptacopan moved forward into its phase 3 trial, which also has not been yet published in manuscript form, but was also presented by Carla Nestor at the 2024 ASN. They kept her busy in C3G. So this was this is called APPEAR C3G is the name of the trial. It's a randomized double-blind placebo-controlled trial. Only included adult patients. It was 74 patients overall, and it was native disease, all with biopsy-proven C3G. And it was divided into two parts. First, a 6-month period where patients were randomized to iptacopan or placebo, and then an open-label extension period where all patients received iptacopan, and the placebo patients were crossed over to receive iptacopan. And here are some notable baseline characteristics from APPEAR. So again, the baseline eGFR was pretty high. These patients had preserved kidney function on the whole. The iptacopan group, 89 mLs per minute, 99 in the placebo group. Baseline proteinuria, again, pretty significant proteinuria at baseline, nephrotic or near nephrotic range, 3.3 grams in iptacopan, 2.58 in placebo. So again, the placebo arm seems like a overall milder group of patients. And when you look at the breakdown of the subtypes of C3G that were included in both groups, this may be why the proportion of patients with dense deposit disease was 23.7% of the iptacopan group, but only 2.8% of the placebo group. And dense deposit tends to have a worse prognosis and just be more quickly advancing than C3GN, and perhaps that explains the discrepancy in the baseline EGFR and UPCR. Okay, so all patients completed the 6-month randomized phase, and they were then offered the chance to continue in the open label extension, and 58.1% completed the full 12 months of the trial. And it was essentially equivalent numbers between the iptacopan and placebos who continued in the extension. Primary outcome was proteinuria reduction, same as with Valiant. And this was reported first at 6 months and then following out to 12 months. And the degree of proteinuria reduction in the iptacopan group was 35.1% compared to baseline. And Dr. Nestor presented, again, a figure which I think does a nice job of helping us visualize the timing and comparative degrees between the proteinuria reduction. So this white portion here on the left is the double-blind period with placebo versus iptacopan. And you can see that the iptacopan group, their proteinuria dropped very quickly. Within 30 days, they had hit that 35% reduction in proteinuria mark. And then they stayed pretty stable at that over the remaining 11 months of the trial. The placebo group during the double-blind period was pretty flat. And then at this point, when they were crossed over to receive iptacopan themselves, they also had a reduction in proteinuria at about 30 days. And then progressively, by the time that we hit the 12-month mark, both groups were essentially in the same place, which was that 35% or so reduction in proteinuria. Same composite endpoint as in Valiant, the 50% or greater reduction in proteinuria combined with a less than 15% reduction in EGFR. In the iptacopan group, 43.5% hit that composite endpoint. And in the placebo group, at the 6-month mark, I think it was 5.6% had hit the composite endpoint at the end of the double-blind period. At the end of the 6-month crossover extension, 25% of the placebo group had also hit that composite endpoint. And then in this trial, they had some historical data in the 2 years preceding enrollment in the trial in terms of EGFR. And what they were able to show was that in the iptacopan treated group, the slope of EGFR decline over the couple of years leading up to the trial was negative 10.8 mLs per minute. And then on the 6-month treatment period, that slope flattened to essentially zero, negative 0.03 mLs per minute, compared with the placebo group, who had, again, a less severe phenotype, it seems like, a flatter EGFR decline at baseline. And then over the course of the treatment period, their decline rate was negative 3.1. And this flattening of the iptacopan arm was even more impressive in the subset of patients who had the heaviest proteinuria. I didn't include that picture here, but in the group with more than 3 grams per gram, that change in the slope was even more marked. And again, a reassuring side effect profile, pretty similar treatment emergent adverse effects between the treatment and placebo groups, and again, no meningococcal infections. And on the strength of these data, iptacopan was approved as of March 21st for use in C3G. All right, so in the last couple of minutes, I'll just kind of give my thoughts on where does this leave us now with treatment of C3G. So I have the same figure that Dr. Sharma used, this kind of complicated flow chart, which boils down to the 4 steps of, again, excluding IRGN, excluding paraprotein-associated disease, and then treating with conventional immunosuppression. And for those patients who don't respond, considering rescue options like eculizumab, terminal complement blockade, plasma therapy in a certain subset. But as you've heard over and over, the outcomes with this treatment paradigm are lacking. So now that we have proximal AP inhibitors available and others in late-stage clinical development, what is the treatment paradigm going to become for C3G? And I think it's just going to become a lot simpler. Again, we'll still have to exclude infection-related disease before treating with these drugs. For now, at least, excluding paraprotein disease and shunting those who do have a paraprotein, again, to hematology for bone marrow biopsy, considering clone-directed therapy, I think that's still going to be the right step because these patients weren't included in any of the trials for the proximal inhibitors. But for primary C3G, these proximal inhibitors are going to become frontline therapy. And a question is, who do we decide to treat, or maybe more importantly, are there patients with C3 who we won't treat upfront with an AP inhibitor? Certainly, I think any of the patients who meet the inclusion criteria of the trials we're going to be treating. Remember that you have to vaccinate against encapsulated bacteria and provide prophylaxis until vaccination is completed. So for summary points, again, the proximal alternative pathway is the primary site of dysregulation in this disease. Proximal AP inhibitors are being tested in C3G and are now becoming available for clinical use. And then here's a few outstanding questions, certainly not all of them, just the ones that were top of mind for me. Again, what should the criteria be for deciding which patients that we treat with these proximal inhibitors? Everyone who has C3G, only those who have some amount of proteinuria, reduced kidney function, a lot of activity on their biopsy? How long do we continue therapy? Is this a lifelong therapy when we start these patients on it, or do we continue until there's remission and then try them off the drug and see how they do? For patients with monoclonal disease, paraprotein-associated C3G, where are the proximal AP inhibitors going to fit into that treatment paradigm? Do we add them to clone-directed therapy? Do we try clone-directed therapy and reserve these inhibitors for resistant disease? And then finally, for transplant patients, where are they going to fit into that paradigm? Do we use them prophylactically right after transplant, or do we wait for evidence of disease recurrence? So these are all kind of outstanding questions that I don't have an answer to, but they're certainly interesting to think about, and I think they're going to be the subject of a lot of discussion and hopefully testing in the future. So thank you.
So now we can open it up for some questions. It's over time, but please come to the microphone and state where you're from and who you are, and ask questions of our panel.
Hi, Jeff Pro from Toronto. I see 3 excellent talks and want to compliment you. Just a question here. You answered one of them. So what do you mean by ruling out infection related? Because, you know, in your multimorbid sick population of the liver disease case, we always worry we're missing a looming sort of subclinical infection. So what would be sort of your, you know, I know it's a box on all the algorithms. What does that mean to you?
So in that particular case, I still kind of stuck with the box recommendations, but it's irrelevant to that case because he was prior to these newer treatments. So it's less important. It's less of an issue when you're giving steroids and MMF. You can reverse those pretty quickly and probably get a hold of it. But we still waited a period of time, and when there was improvement, then we thought the infection was reasonably ruled out. There are no markers for these infections, and that's the problem. You can't do a blood test and say that they have still have some subclinical infection or some post-infectious process that needs to be resolved. So I think we wait a period of 6 weeks to 3 months, and if there are still persistent, that we go ahead and initiate more advanced treatment.
Thank you. And then one more question was about the complement mutations and prognosis. Is it follow a similar trajectory to atypical HUS where the different mutations have different prognostic implications?
Do you know the answer to that?
It's a great question.
It is a really good question.
Yeah, I don't have a very good answer to that question. I know that, some of the autoantibodies, for example, will be treated with sort of B-cell blockade or eculizumab, right? So, but is one type of genetic mutation worse than the other? I don't know. I don't know if the atypical HUS data sort of extrapolates into C3G. I don't have a good answer.
And the reason for using eculizumab is an extrapolation from the atypical HUS. So, and it doesn't work very well in the studies that I reviewed.
So hi, thank you so much for those talks. I'm Iris, I'm from Temple, and I recently got the Factor B inhibitor approved by Health Partners for my C3G patient in North Philadelphia. And it is $900 for one pill twice a day, so it's $1 million therapy for the year for her. I have two questions. The first question is, in the PEG trial and in the Factor B inhibitor trial, was the placebo arm on MMF, or were they for both trials? Or?
Yeah, so both trials allowed patients to be on a stable dose of immunosuppression. I can't give you the exact numbers, but I think in the PEG trial, it was somewhere on the order of like 40% or so were on another immunosuppression.
Not required.
Yeah,
okay.
Yeah, but it wasn't required. That's right.
It wasn't
That's right.
required. Okay, and then my second question is that given that these autoantibodies, against complement regulators might be, driving disease in some, are we going to give up completely on B-cell directed therapies now that there might be like more, powerful B-cell depletional agents, or, give up on plasma, not even consider plasma exchange ever? Just wanted to know your thoughts on that.
Well, I'll ask my peers to answer this as well, but plasmapheresis has been utilized for a while in this disease and doesn't seem to have a large role in the C3Gs. Rituximab has also been used, and it doesn't seem to alter the course of the disease state. So I do think that once we have some of these more specific therapies, that we can return to some of these others that may be adjunctive to the treatment and add to it. But I think that as standalones, they haven't been effective.
Thank you.
Yeah, I agree with that. I think presumably the proximal AP inhibitor should still work. But yeah, I would think that in an adjunctive role, blocking the proximal AP and removing the causative antibody would probably give you the best outcome. But hopefully we'll get some reports as people start using this. They'll be reporting on people who have like factor H antibodies and things.
Hi, excuse me. Hi, Roger Odby from Rush in Chicago. So Purva, I'm going to clone you. I'm going to shrink you. I'm going to keep you in my pocket for all my complement questions, because that's just not ever going to happen in this brain. But I do have a question for you. We keep stressing this monoclonal gammopathy-related etiology in people over 50, and it was over 50. It was over 50% of them, I think. It was a large percentage.
Deposit disease.
And you don't always find a monoclonal gammopathy in people, and you don't always find it in their serum, and you don't always see it light chain restriction in their biopsy. You mentioned pronase restriction, or pronase digestion, rather, to look for that. So what does everybody, assuming if you find a monoclonal gammopathy, patient 60, you find a monoclonal, that's fine, that's easy. What if you don't find it? Do you think all these patients need to have pronase digestion?
So, this is not, so you might not find evidence of monoclonal gammopathy on the kidney biopsy, because the way the monoclonal proteins actually cause C3G is by acting as nephritic factors. So they're ultimately acting against the complement pathway. So they're not necessarily causing something actually on the kidney biopsy. So the kidney biopsy is not showing evidence of monoclonal disease. So it's not really, you're not trying to find find the, kappa lambda restriction on the kidney biopsy. I think I might have, it may not have been clear. The pronase digestion was to find immunoglobulin, like IgG, for example, sometimes, but not necessarily kappa lambda. So the monoclonal proteins are acting as nephritic factors, in basically activating the complement pathway. So the kidney biopsy finding is still C3G. Yeah, of course.
I got confused.
Oh, it's okay. I think the person who asked right before this about rituximab. So one is the factor H autoantibody. So in that case, rituximab definitely helps. About nephritic factors, we don't have good evidence for rituximab in nephritic factors. And remember, there's been a lot of diseases lately, including IgA, that we know are antibody mediated, but, rituximab doesn't work for all of these diseases because, there's a specific milieu of all of these diseases, the way they act. And rituximab is very, it's a general sort of CD19 blocker. So it's really, it doesn't work in a lot of conditions that we would assume it would work, but it really doesn't. And then we try to figure out why it doesn't work in these situations. So C3G is just one of them. But yes, for factor H autoantibody, yes, rituximab is an option.
So there's some number of questions from the audience. One I'll settle right away. My case, I said a hemoglobin of 34, but it was a hematocrit of 34. There are some other real questions here. So do patients with C3G and that was a real question. What's that? Okay, so I can't read these out, so we'll try to answer them as best we can, and because we have to clear the room for the next session. Absolutely. Yeah, we